Hello, my name's Tom Stinchcombe. I'm a medical oncologist at Duke Cancer Institute, and I specialize in thoracic oncology. My primary focus is on clinical medicine and clinical trials and bringing novel therapies to patients. And it's my pleasure to join you today. So BRAF mutations are seen in about 3% of all lung cancers, but only for half of those with a BRAF mutation actually have the BRAF-V600E. And this is a mutation that is very common in malignant melanoma of the skin and is seen in lung cancer. What we found is that we've developed a targeted therapy for this group. We initially developed one targeted therapy, dabrafenib, which is a BRAF inhibitor, but we found that the response rates were relatively low and the disease control duration was relatively low. And we've now moved to combination therapies with a BRAF inhibitor and a MEK inhibitor. So most of the time when I see these patients, I start the two drugs together because I think the higher response rate and longer disease control is important. There's obviously more toxicity with two drugs compared to one, and you have to be ready to adjust the doses and monitor these patients closely. But when the drugs work, they work for a prolonged period of time. And I've actually had some patients stay on them for 2 years or more. Very dramatic responses, by the way. And so I think we really want to make sure that we test for this and get them on the appropriate therapy. In my personal practice, if I see a BRAF-V600E, the targeted therapy is the preferred first-line option. I don't use immunotherapy, or I don't use chemoimmunotherapy. I go right to targeted therapy. There may be some debate in the field, but that's my practice pattern. I use the combination of the BRAF inhibitor dabrafenib and the MEK inhibitor trametinib because this is the FDA-approved combination in lung cancer and the one that's most well validated.